Welcome, everyone. Thank you so much for joining us for our Understanding Tardive Dyskinesia talk with NAMI Palm Beach County and NAMI Miami. We're happy to have you all join us today. My name is Jackie Wright. I'm the Director of Programs for NAMI Palm Beach County. I would like to introduce our speaker today, Dr. Patrícia Ares-Romero. I'm going to read a quick bio. So as a reminder, this lecture will be recorded, and we ask that you can ask questions throughout the presentation. Please raise your Zoom hand or pop your question in the chat. So Dr. Patrícia Ares-Romero is the Chief Medical Officer of Dr. Ares and Associates Consulting, responsible for expanding the behavioral health offerings and substance use treatment locally and nationally. Dr. Ares-Romero is double board certified and a diplomat of the American Board of Psychiatry and Neurology. She is a diplomat of the American Board of Preventative Medicine as a specialist in addiction medicine. Dr. Ares-Romero has served 2 terms as a NAMI Miami-Dade County Board Director. Dr. Ares-Romero is currently President-elect for the Dade County Medical Association. She was an associate professor for the University of Miami School of Medicine for the Departments of Psychiatry and Anesthesiology Pain Medicine Fellowship. In 2017, during the opioid epidemic, she was appointed by the mayor to the Miami-Dade County Opioid Addiction Task Force. She is the chairperson of the Addiction Advisory Board for Miami-Dade County. She also serves on the Health Impact Council for United Way Miami-Dade County. Dr. Ares-Romero served as the Chief Medical Officer for Jackson Behavioral Health System, implementing various programs throughout the health system. And just a brief disclaimer, please note that the views expressed by the presenters do not reflect those of the National Alliance on Mental Illness, NAMI Palm Beach County, and are the views of the presenters only. Moreover, NAMI does not endorse any treatments or therapies as expressed by the presenters. All right, and with that, I'll turn it over to Dr. Ares-Romero.
Well, thank you. Thank you so much, Jackie, and welcome everyone this afternoon. I hope everyone's having a lovely day. So it is Tardive Dyskinesia Week, Awareness Week. So I think this is very, very wonderful to be able to do it during this week. So understanding tardive dyskinesia, this is one of the subjects I love to talk about. And as a matter of fact, a couple months back, I presented to many providers, both physicians and nurse practitioners, on the importance of not only how do we treat it, but how do we identify it? Because for so many years, we really were not identifying tardive dyskinesia. And I think some of the shortcomings, we just didn't know how to treat it. We just didn't know what we were doing. So with that, let's kind of get started. And what are we going to do today? So today we're going to really identify and understand the symptoms of tardive dyskinesia, the differences between other movement disorders, which is very important because we would manage them differently in lieu of them. So the importance of having an AIMS test done for patients, and really what are the evidence-based practices in order to treat patients with tardive dyskinesia. It's different. It's definitely a clinically distinctive movement disorder, and the culprit is dopamine blocking agents, mainly antipsychotics. So, when we have patients that present, we have to look at their clinical history and see, have they been exposed to a dopamine blocking agent? And if so, for how long? So it usually can develop within 4 weeks of either with exposure within 4 weeks or withdrawal within 4 weeks. So a patient has been on it, and within the next 4 weeks, they start developing these symptoms. This can be an indication that's tardive dyskinesia. Now, if they've been on a long-acting injectable, it could take as long as 8 weeks for this to happen. So least use, they have to list being on the agent for at least 3 months. Or in patients that are a higher risk factor, such as those over the age of 60, you would see that at least 1 month of treatment with an antipsychotic, they can develop tardive dyskinesia. The other thing that's interesting to note is that, we usually think of tardive as being something that's mainly in the face, in the oral buccal area. But in reality, it can happen anywhere in the body, anywhere from the top of the head to the bottom of the feet. And in fact, we see it very often in the feet of patients. And also, tardive dyskinesia can wane and wane and wax throughout the course. So some periods of time the symptoms could be a little bit more serious, and other times they may not. But it's basically irreversible when it does happen. So dopamine blocking agents. So, unfortunately or fortunately, we do have antipsychotics that do treat illnesses such as schizophrenia, bipolar disorder. It's also used for adjunctive treatment in major depression disorder. Agitation due to dementia, which really it's not indicated, but we still see it happening. And some people use it for the benefits of sedation, which I do not recommend because, knowing that there's a risk factor for tardive dyskinesia, we shouldn't be using antipsychotics just for the benefits of sedation or sleep. But the other thing that sometimes we don't know and we don't realize, or other providers that are not in the mental health field, antiemetics for GI disturbances also are dopamine blocking. So things that we might take for dyspepsia or nausea and vomiting can also cause that dopamine blockage. And if we do have, maybe that agent plus another agent together at the same time, the incidence of tardive dyskinesia can increase just because we're having much more blockage of the dopamine system. So what are the patient risk factors? So number one, being over 50, you have a higher risk factor for tardive dyskinesia. If you have a diagnosis of a mood disorder, we're not sure why this is, but it does tend to happen more often. Postmenopausal women also are at a higher risk, and patients that do struggle with substance use disorder or abuse also have a higher incidence of tardive dyskinesia. Now, the treatment factors. So that was a patient factor. So actually the factors that contribute to a patient. Now there's treatment factors, and those are cumulative exposure to antipsychotics. So the longer you've been on an antipsychotic, the higher the doses, you tend to have a higher risk factor for developing tardive dyskinesia. Anticholinergics can actually be counterproductive. So treatment with anticholinergics has been found to also contribute. So that's why it's really not used for tardive dyskinesia. And this is one of my big things, trying to educate providers on putting a patient on an antipsychotic and an anticholinergic for preventive practices or prophylaxis, which is really not indicated. Because if they do develop tardive dyskinesia, this could be kind of work against them. History of acute drug-induced movement disorder. So if a patient has had akathisia in the past with an antipsychotic, or has struggled with maybe an acute dystonia reaction, they're at a higher incidence for tardive dyskinesia. So these are things that we need to consider. Also, the higher the potency of the antipsychotic, the more blocking of the dopamine 2 receptor, you can lead to higher incidence of tardive dyskinesia. So these are the treatment risk factors that we need to consider, or providers should be considering when treating patients. So I trained from 1999 to 2003 in psychiatry. And back then, when the second generation antipsychotics were coming into market, we believed, or we were under the assumption that the second generations were not going to be causing tardive dyskinesia. As a matter of fact, we thought they weren't going to be causing a lot of side effects, which unfortunately is not the case. So the studies have been shown that anyone can develop tardive dyskinesia. It's anywhere between 7 to 30%. When they're prescribed an antipsychotic or take an antipsychotic. So, it's a high percentage, right? So there was a meta-analysis in 2017, and they showed that if patients had been exposed to a first-generation antipsychotic, they have a 30% chance of developing tardive dyskinesia. And first generations are those such as haloperidol, also called Haldol, or Prolixin, which is another one, which is also called fluphenazine. So those are the first generation. And by me saying this doesn't mean that they don't have a place in treatment, and there's patients and a place in treatment where we need to use it and we should be using it, but it shouldn't be the first line of treatment for patients. And so there's over a 20% chance, if they have been exposed to a first generation and then they are exposed to a second generation, that they can develop tardive dyskinesia. And then for those that have never been on a first generation antipsychotic and only on a second generation antipsychotic, there's a little bit over 7% chance of developing tardive dyskinesia. So this is just to say that, although second generation antipsychotics have much less side effects when it comes to tardive and movement disorders, it's something that we still need to be concerned with and look at. And again, I prescribe antipsychotics all the time. They're great medications. They work great for our patients, but we always have to be cautious, look at the patient risk factor, look at the treatment history, and then also, make sure that we are, evaluating patients. So this is something that I'm really glad was done because, and we'll talk a little bit about the APA and what they decided to do on recommendations for tardive dyskinesia. And so, originally the APA came out and said, well, listen, if it's moderate to severe, then you should be treating, right? But that's not really fair, right? Because if it's not moderate, according to the AIMS, which is the scale we use, and I'll talk a little bit about that, if it's affecting the patient, why shouldn't we be treating them? Right? If the patient comes to me and says, hey, doc, you know what? I'm not feeling well because my tremor is not allowing me to put on lipstick, right? And maybe for someone that might not be important. But for a patient of mine, this is a true case. For a patient of mine, that she loved to socialize and she loved to be out. And the fact that she couldn't put on makeup or put on lipstick was very impactful for her. So this study in 2019 showed that the majority of these patients were being affected. And that was a negative impact on their ability to be out in public, to be able to, relate to others. So 76% reported an effect affecting their confidence. Sorry about that, the E kind of fell down. 73% affected their self-esteem, and 69% said it affected their self-worth. So these are impactful things, right? Because if it's affecting the way I'm feeling, it's going to, affect my socialization. I'm going to be more withdrawn, more isolated. So these are things that are very impactful to patients. So it's not only about, clinically or according to our scales, it's also how is it affecting the patient? On the physical impacts of function, like I said, it can happen anywhere in the patient's body. And one of the things that we find most common is difficulty in eating and swallowing. You can have tardive dyskinesia in your tongue. You can have some jaw thrust, which we see a lot. And so this can really affect the way you're eating, swallowing, your appetite. And in the older population, and we see this in nursing homes, they can have aspiration pneumonia because of this. So very important. Dental impairment is also done because sometimes there's a lot of jaw thrust and clenching of the teeth, which can cause dental issues, strength deficits, as well as decrease in motor activity and joint flexibility. And with this, we see with the patients that it really affects their truncal area. And I usually, when I present a lecture in person, I kind of do the movements kind of to really for impact. But yes, it can affect their truncal area. So it's very difficult for them to kind of really have that balance or do any kind of strength training exercise, which is so important for our well-being and longevity. So things like that, they're not sometimes, and also in the older population can cause falls because there's that instability, of the hips, of the legs. So physical impacts, not only the emotional, like we mentioned, but that there's a physical.
We
So
also have a question in the chat. Does early treatment improve outcomes?
Yes. So we should be, and we'll talk a little bit about that. We should be assessing and evaluating patients early on. And so that's kind of perfect sideline for this, right? So the APA came out with practice guidelines for patients that are taking antipsychotics, and at each visit. So the recommendation is every single visit, we should be evaluating patients for this. We don't have to do the formal AIMS, and we'll talk about the AIMS, but we at least need to evaluate our patients, in my clinic and in the office and wherever I talk to, residents or students is, have the staff understand tardive dyskinesia because sometimes they spend time with them, right? They're in the waiting room, you have the receptionist, you have the MA, you have all these folks that are kind of seeing the patient. And what happens many times is that if the patient is self-aware, right, when they're talking to you or to someone, they might sit on their hands, right? They might try to really hold the mouth from moving because they're embarrassed. They notice that this is happening. So, but when they're relaxed, they might not be so aware of it, and then the movements become more clear. So, and I let them kind of let me know about that. So we should we should definitely be looking at our patients every visit to make sure that there's no new movements. Another thing I like to do is I like to ask the patient, has any family member or friend noticed any different movements or mentioned movements to you? Because sometimes the patient might not realize it, right? But they'll notice, or patients come in and go, is that tremor on your hand new? So things like that. And sometimes they'll say, you know what, it's true, doc, I think my sister said something about me twitching my head a little bit too much. So those are the things we should be doing. So the AIMS is a scale that we use. It's a clinician scale where we evaluate the patient, we're the observer, and it's 12 items. And it's really there to assess, the severity and the progression over time of the AIMS. And hopefully, if we're treating correctly, the decrease in the movement disorder. So APA says every visit we should be visualizing a patient. If a patient is a high risk, like we mentioned, either because of patient high risk or treatment high risk, then we should be doing a formal AIMS every 6 months. And if they're not at high risk, then we should be doing it at least once a year. I personally think it should be done more frequently, but at least every time you see the patient, you are really taking the time to look for movement disorders and ask the questions, we should be able to detect it early on.
We have 2 questions in the chat.
Yes.
The first one is, can these patients benefit from occupational therapy to improve, I believe that's upper extremity strength deficits, and provide these patients with adaptation and compensatory exercises to improve ADL's performance?
Yes, I mean, I always think that any kind of PT or occupational therapy is always very, very beneficial. I'm a huge advocate for strength training and exercising for everyone, and it doesn't matter what the age is. So, even if you're 70, 75, and you've never exercised a day in your life, we should be moving. We should be moving using resistant bands. It's our muscle of longevity. It's really what's going to keep us alive, prevent us from falls, and prevent us from being sick. So yes, if you're able to do that and that's able to be done, yes. I advocate for us being able to prescribe that. And the challenges are, as I'm probably preaching to the choir, is that insurance is always a hassle with things like that. It's one of my priorities as a incoming president for the Dade County Medical Association. We're huge advocates. I go to Tallahassee all the time to get more benefits for our patients. Sideline, last year we were able to get Medicare rates for Medicaid patients in the adolescent and children population. And we're trying to do that now for the adults. So those patients that have Medicaid, that they'll be able to get the same benefits as a Medicare patient. So that's, still to come, but we're really advocating for that. And so things like this are very important. Thank you for your question. I love the questions. What was the other one?
One more question. Can a long history of ADD meds cause this?
No, not tardive dyskinesia. Now, what could happen with attention deficit, so stimulants basically is what we're talking about. There could be some jitteriness and nervousness and anxiety, and then maybe we just need to bring down the medication or switch to another one. But tardive dyskinesia only happens with dopamine blocking agents. So the guidelines that we recommend, and if there's patients in the audience or family members, you should advocate for them to do that, for your provider to be looking out for this. And if you observe something of this, you should be talking to your provider. And if your provider's not listening to you, you need to switch. And your biggest patients are their biggest advocate, and so are our families. I love when families come in and talk to me about the patient. So if they don't want to hear you out, they don't want to listen to you, move on. Let's find somebody else, because you need to be heard and listened to. So so when they're coming in the room, we're observing the patients. It's very important, because that's when we are seeing their actual walking. And I know this is more for like the provider base, but I think it's good information for anybody. So we want to see how they're walking, right? We're going to talk now with I'm going to talk about a little bit different between the Parkinsonism versus tardive dyskinesia versus dystonia. And the walking has a lot to do with that. So, the tongue at rest. So, we do ask the patients to, take out their tongue. You know, we want to see, you know, what the movement is like. We ask patients to take off their shoes and their socks because we want to see the feet. It's very typical to have piano-like movements of the hands, which is a little different from the other movement disorders, but we call it the piano-like. So those are the things that we're looking for. A lot of the facial movements, blinking, you see a lot of blinking with tardive dyskinesia. And then again, movements of, you know, it could be anywhere in the trunk, the legs, and my feet. We should be looking at the feet all the time. It's a little caveat, and I talk to neurologists about this all the time. Sometimes they diagnose restless leg when it's tardive dyskinesia. They think it's so restless leg only happens at rest and at night. It doesn't happen the entire day. So there's a differential diagnosis. And if you know, the neurologist, the providers think it's restless leg and it's not getting better, we should maybe go back and look at it again. So that's just a little caveat for you guys. All right, so in the era of telehealth, it's, you know, we see our providers. There's a lot of providers are going hybrid, right? So you have the brick and mortar, and then you have the patients that you see telehealth. So, you know, some of the things that you should be looking into, again, if you're a patient or a family member, or even if you're a provider, you know, laptop or tablet is a little better because we have much more visual field for you to be able to see the patient. When a patient is evaluated during the Ames test, you cannot have the arms with arm rests because you can't see me. But if, let's pretend this is the armrest and I have my arm on the armrest, you're not going to be able to see that movement. You're not going to be able to. So it should be in a chair with no arms. And that's what we do in the office. And that's what we should be doing, even if we're doing telehealth. And then again, kind of, you know, repeating myself, the lips, the face, stick out your tongue. You know, we sometimes will ask patients to do like this movement, right? And the reason why we do this is not to see if they can actually have this fine finger movement, is when we're doing this, they're so concentrated on this that then it will elicit some of the movements, even if they're very minor and they're just starting. And then that's why we do that. If a patient's not able to do this because, let's say, maybe they had a stroke, or they're not able to hold up their arm, then we'll do it with mental. So we'll have them count backwards. So there's different ways of doing it. So, and then of course, like I said, you know, love taking off the shoes and the socks. Some patients are like, what? And I'm like, no doctor has ever asked you to take off your shoes. So, so I get some pushback sometimes, but it's okay.
We have another question in the chat. We have, should all psychiatrists who prescribe antipsychotic medications do the TD exam?
Yes. Yes, you have to do it at baseline. So, so the aim should be done prior to prescribing a medication, an antipsychotic. It should be done before, right? We want to make sure we have a baseline, because if the patient happens to have an essential tremor, right, which is a familiar tremor, and an essential tremor is a tremor where if I'm going to grab this, it's only when I'm going to grab it, right? It's an essential tremor. But if I'm at rest, I don't have it. But I'll document that, because then if I don't see the patient, I'm not in clinic that day, I have an APRN that's seeing the patient 3 months later, sees that, and it's not really, that's not their area of expertise. They'll say, okay, wait, no, that was an essential tremor. They don't have TD. I hope that makes sense. So yes, the answer is yes, they should be doing it at baseline. We should be observing our patients every visit, and then high risk every 6 months and every 12 months if they're at low risk. Any other questions or?
No, that's it.
All right, great. So yes, they should be. And if not, again, change. For any psychiatrists, they're going to hate me, but
I did have one other question. You might get to it later, but if
yeah,
just to plant the seed about telling between Parkinson's and TD.
we're gonna go into that. So if you give me a couple more slides, we're gonna look in that, because actually this one starts it, and then I'm gonna go into a little bit more detail. High level, but just it's kind of those things. All right, so hyperkinetic movement is what tardive dyskinesia is, which just means increased movement. Kinetic movement, hyper, extra, or increased, right? So it's really associated with an increase in dopamine signaling. So although we're blocking, and I know it's so hard even for medical students to understand, and residents sometimes. So even though we're blocking the dopamine, because we're blocking it so much, there's other receptors that are coming online. And then more dopamine is being released, because it's kind of our body's way of kind of, you know, that biorhythm, right? To kind of help itself, because we don't have enough dopamine. So it's an associated with an increased dopamine signaling, which means that it's a lot of dopamine being released, mainly the neurostriatal pathway, which is where those movements are caused by. Now, on the other hand, when we have the Parkinson-like or Parkinsonism, that doesn't mean it's Parkinson's, it's just caused by the antipsychotic, because Parkinson's, although it's low dopamine signaling, it's a different mechanism. But anyway, this is drug-induced. So drug-induced Parkinsonism, it's a hypokinetic, again, kinetic movement, decreased movement. So this is what we see when we have low dopamine signaling. So there's low dopamine, high acetylcholine, and that's where we have that very, very slowing of movements. So you'll see, and I'll talk about it a little bit more in the next slide. So for instance, perfect example for you to be able to visualize it. In tardive dyskinesia, we're going to have a lot of blinking. This is how it is. Or movement, mouth movement. In Parkinson's, decreased blinking, barely blinking. And then there's what we call mask facies, which is just blunted. Very little to no movement. Very blunted. And we see that in Parkinson's disease, but also in the drug-induced Parkinson's. So this is a little bit more kind of to distinguish, right? Between it. And I chose 4 because these are the 4 that we see with antipsychotic use. So we're going to talk about what the symptoms are, what does it look like, when does it start, and it's going to be a little bit, sometimes a wide range of days to months. And then what happens if we increase the antipsychotic or decrease the antipsychotic. Okay, so starting with tardive dyskinesia. So it's a very repetitive movement. So if you see the hands, but it's not really rhythmic. It's very purposeless, rapid, jerky movement. Can be slow, continuous, and it can affect any body part, anywhere in the body. So it's a lot of movement, a lot of expressive movement of the jaw, thrusting. Sometimes there's rocking, right? Again, not rhythmic, but just, kind of this, right? All right, that's tardive dyskinesia, and then we'll talk about when it starts. So it's usually weeks to years. So we said it. So if somebody has been on an antipsychotic, 1 to 3 months, they can start developing it. Now, drug-induced Parkinsonism, it's the slowing of the movements. The patient's going to be very rigid. There's a thing called cogwheel rigidity. So if you take the patient's arm, it's part of the physical exam, right? You try to open it. That's why it's called cogwheel. It's really hard for them to close it because they're very rigid, very, very rigid. Reduced blinking, I mentioned that already. Reduced movement of arms. So when they walk, how we usually walk, right? So the arms will be really reduced, so kind of stiff. And then the very classic gait, which is it's called the shuffling gait. So it's kind of like if they have a magnet at the bottom of their feet, and they have to kind of pull their foot up to move. So that's drug-induced Parkinsonism. Now, this can start earlier. This can start earlier on, days after starting an antipsychotic. And usually we see it most commonly with the first generation, or sometimes second generation at higher doses also it's seen. Acute akathisia. So acute akathisia is one of those that we tend to see a little bit more often, I believe. Easy treated easily. And so it's an inner feeling of restlessness. So you'll see the patient, and I'm always so so you see them, they'll get up, they'll sit down, they'll move around, they just can't stay still. And you ask them, and most people think it's anxiety, right? So if a writer's not, hasn't seen this or doesn't really know, will be like, oh, you're just anxious. It's not anxiety, because you'll ask the patient, and it's this inner feeling. I can't. So I always like to ask the patient, does it feel like ants in your pants? Kind of. And most of the time it's like, yes, that's exactly what it feels like. So it's this inability to stay seated. There might be some foot tapping. So, and again, not everybody that foot taps is akathisia, because some people just have a bad habit of doing that, right? Or kind of moving their legs or shaking their legs. That's different. Rocking or moving. So sometimes they'll come into my office and they'll just be like, and again, people might think it's, ADHD in addition to whatever else they have. So you have to be very, very careful when you're looking at this. Akathisia, inability to stay still. They just can't help themselves. And I usually see it as soon as they're walking in the door. I could tell. I'm like, how long have you been like this? And it's usually days to months after starting. So again, it's much earlier on symptoms that they see. I see it more and I know this is anecdotal and there's no evidence base. I haven't done a study. I'm just throwing it out there with aripiprazole oral. I see it a lot more. I've seen it just anecdote, not that it's good or bad. I use it. But if you are on that and you have these movements, you need to switch. And that's usually what I do. I usually take them off whatever agent it's causing the akathisia, and it goes away. I mean, it's wonderful because it's one of those things that we can just treat right away. Just take away the agent that's affecting it. So again, days to months. Now, acute dystonia. Acute dystonia usually happens, and I'll tell you, when I used to work in the emergency room, hours. I had a patient that once came in and the resident gave them, haloperidol. It was needed. They were very agitated, very aggressive. And as soon, I would say maybe 2 hours, I came back to do rounds. And so dystonia, and let me just maybe tell you what it is first. Okay, so dystonia is it's usually to one body part, and it's a pulling or twisting of sustained muscle. And it's very, very focal. So you'll see it here. It can happen in the eye, binocular gyrus. It can happen in your arm, your truncal area. And so it's very painful. It's very painful because imagine a contraction of that muscle area. So anyway, so this patient, and I saw him and I was like, oh my gosh, this was a Haldol right away. The good thing is you treat them, IV push, and it goes away right away. It's just right away, goes away. So that's another one that you can really treat really quickly if you need to, if you are able to identify it and know what it is. Okay. So how do we treat them? So tardive dyskinesia, if you decrease the antipsychotic, and that's why at the beginning of the lecture, I said, sometimes when you wean them off the medication, this might come out. Because what happens is as you start taking the antipsychotic, it unmasks the actual movement. So that's when you might see it. So it usually worsens when you first take out the antipsychotic. And if you increase the antipsychotic, it usually masks the symptoms because again, you're starting to block more of the dopamine, right? So you're blocking more of the dopamine, the symptoms seem to kind of release. Anticholinergics, and anticholinergics are things such as Benadryl or the famous Cogentin. They're not indicated and actually can make it worse. And I know everybody throws Cogentin at everything, I know, but it's really not something that we should be giving prophylactically to patients just because, so some doctors or some providers are giving an antipsychotic and prophylactically Cogentin because they think they're going to fix this, but that's not the way it works. And actually, if you use anticholinergics, for a very long time, there's also side effects. So we need to be aware of that, especially in the elderly population. So that's not the treatment. We'll talk about the treatment a little bit later. Drug-induced Parkinsonism, if you decrease the antipsychotic, it usually improves. Switch it to something else. Maybe try another antipsychotic, and that usually improves. And then anticholinergic does work for this condition. So this one, there's a treatment for it. We treat, we decrease, we discontinue, we switch to something else, and we can also use Cogentin, Artane, or Benadryl, whatever we prefer. Acute akathisia, how do we treat it? Again, you decrease the medication, take it, I take it away. I just take it away for both of these. I just take it away, let's start fresh. Unless if in a case where a patient has been on everything and this is the only thing that's really worked for them and they're stable, then we try to decrease the dose, and then we try to see if maybe we can, cross taper with another medication, something like that, if that's the case. But if it's something that was recently started, let's just kind of discontinue and start all over. And anticholinergics really don't do much for this. Acute dystonia improves as soon as you take away the agent that caused it, and of course, never use it again. And anticholinergics can help with this condition. So that's it on this. Is there any questions on this slide? Because it's a pretty heavy slide. with a lot of information. No, okay. All right, so kind of to sum it up.
Sorry,
Oh.
just to kind of recap in my mind, it seems like it can be very dangerous if a doctor diagnoses you with the wrong condition, because these drugs can worsen your symptoms.
Correct. Right. So and that's why it's so important to have the distinction between all four of them, because they're treated differently.
Yeah.
So yes.
Just to recap, because that was really standing out to me, that these things might look similarly, but really respond differently to the medications.
Yeah, and you'd be surprised that, I do a lot of education, of providers, and a lot of times they don't know the difference. They really don't. So, and we should know. If we're prescribing something, we should know the side effects and how to treat it. So, again, here to your point, can be confused with other drug induced movement disorders. Yes. The difference with Tardive. So Tardive, the name says it, Tardive delayed. So that's why it's a little bit more delayed than the other ones, and that's also a clue, right? The other ones tend to happen sooner in the course of treatment than Tardive. So Tardive is something that we always have to be looking at. And then we do have medications now that treat it. And you should be giving your patients a VMAT2 inhibitor for patients that present with tardive dyskinesia. I mean, that's period, the end. There's no reason for us not to be treating it at all. So the Tardive Dyskinesia Management and Recommendations, APS and APA, the American Psychiatric Association, which I just came from the conference now, in 2020 did give the guidelines, and that's when they said, moderate to severe or disabling tardive dyskinesia should be treated with a reversible inhibitor of the VMAT2 system. But also should be considered in those patients based on their preference and associated to what they perceive to be their impairment, whether it's psychosocial or emotional impairment. And that's what we should be doing. Now, other strategies and treatments. So always consider decreasing or switching to another antipsychotic. That would be kind of the first line of what to do. Because again, if we find that there's another antipsychotic that can really target the symptoms that we're trying to treat without being as aggressive on the D2 receptor, then that might be solved the problem. There's some research, and I looked it up. So there's some research on vitamin B6 supplements, melatonin, and vitamin E, which have helped to help with tardive dyskinesia. And in some cases, a little bit of clonidine or benzodiazepine may help, but of course, everything has secondary side effects. So we always need to look at the entire picture. So, when I say these recommendations, we really need to look holistically at the patient and see if these are some options that would be beneficial, right? Because it's always do no harm. So in summary, this is really what we should be doing. Early recognition is key. We really need to be looking at patients. We need to know what it is we're treating, and if an antipsychotic is appropriate. There are cases when, patients come to me for a consult for a second opinion, and, again, not to name names, but quetiapine, for instance, which is, and I'll be, why are you on quetiapine? And they're like, well, I use it for sleep. Well, quetiapine is not for sleep. It's an antipsychotic. And now we've just increased your possibility of getting tardive dyskinesia. So maybe we can do something else for sleep, right? As opposed to using quetiapine. That's just an example. So, making sure we're treating with the right medication, the right diagnoses, obviously. So, we have to monitor those patients, even if let's say a patient comes to me and I do their clinical history, and they say, they were on a first generation antipsychotic, in 2000, and then they were on a secondary, on a second generation antipsychotic, maybe, 2010, but now, we decide to use a mood stabilizer as opposed to an antipsychotic for them. I still should be, at least once a year, making sure they haven't developed tardive dyskinesia, right? So we should at least be kind of looking at that for those who previously have been in a first generation or second generation, or are currently taking it. So we need to make sure we monitor that. It's very important. And I know somebody asked in the audience earlier, should everybody be doing this? Absolutely, yes, 100%. We need to be able to recognize it. So the only way we're going to be able to recognize it, we're actually assessing or monitoring our patients. We need to be always looking for those involuntary movements on a routine basis. It should be part of kind of our protocol, so to speak, when we see a patient. They're on an antipsychotic, just the same way we should be checking their labs, right? Because we can't forget that. Patients with second generation antipsychotics, you should be checking their labs for lipid profile, for blood glucose. That's a whole different lecture, but anyway, that's those kind of things that we still do. We should be doing this as well. And then again, we should be differentiating between akathisia, drug-induced Parkinsonism or acute dystonia. And then obviously treat with a VMAT2 inhibitor to treat the symptoms. If they're still, despite everything else we did, if they still present, then we should be treating with a VMAT2 inhibitor. And that is it. Thank you. And I will take any questions you may have.
Thank you so much, Dr. Ares-Romero. I am going to stop the recording and then we'll go ahead with questions.
Perfect.